from Stanford University.
Sunil
First,
Srivastava from the Cole Eye Institute.
Thank you, sir. Appreciate it. First, let me thank the group from Bausch & Lomb for their support, continued support for COBRA. We are
year
in
three.
This
is
year three.
Year.
When I called Prithvi and told him this like fantastic idea, I had a half drunk. He's like, "There's no way we'll make it past year one," and here we are, year three. So
I love being proven wrong. Yeah, this is great.
So what do we talk about today, Prithvi?
So today's topic is I didn't know I could do that. So the point of COBRA is for our surgical fellows from our two institutions to share their journey through their surgical growth as fellows and then vitreoretinal surgeons. The purpose of COBRA is really to keep this at the level of the learning process for fellows. So, circle of trust, or everyone here on the call is going to be seeing, fellows kind of taking their journeys, making decisions that don't always seem to go right, but it's the process of trying to fix those decisions to have the best outcomes for patients. So it takes a lot to share our cases with colleagues. It's very easy to show like the super awesome cases that go great. It's really hard to show the cases where there may be some indecision or things that just don't go quite right. So we give it up to our fellows that we throw into this cauldron of pain that we call COBRA, to be able to share and help us all learn. And in order to do that, we have great mentors that have kind of seen them through these cases that will kind of guide along the way. So today's theme is, this early part of the academic year, being asked to do things in surgery that you really didn't think you're either ready for or able to do, but somehow got through. So with that, I guess we'll get started. Sunil, anything else to add? Any ground
Yeah, that
rules?
was a really emotional moment I think we all had there and shared with you.
Sorry,
I think it was amazing. I think it took a while to write that one out. No, I think this will be a lot of fun. Please, in the chat, feel free to join in with the discussion. I'm going to let you take it away, Prithvi, and introduce the Stanford crew.
All right. So starting off is our first presenter, first year surgical fellow, Jared Sokol. Jared joined us from Boston, from Mass Eye and Ear, and is going to take us through his case. We have two mentors from Stanford this evening. The first is Dr. Carolyn Pan, who's our residency program director and directs our Santa Clara Valley diabetic hotspot clinic and service for us. And Ehsan Rahimi is also going to be joining us as our second mentor. So Jared, take it away.
All right. Hey, everybody. Thanks so much for having me. You're
going to do great, Jared. I believe in you, buddy.
Oh, thank you.
Good luck.
All right. Let me just share my screen.
It's already starting great. We've shared the screen properly. We're on a roll.
I was going to say this is an improvement from last year now that Hadi has left our COBRA group.
Ouch.
Love you, Hadi.
Love you, Hadi. On the way out. I spoke too soon.
Spoke too soon.
There we go. Give me 1 second. Yeah.
All right. Well, we have the new Hadi. This is going to be awesome. So we got, it's clear that we're going to start asking for PowerPoint and video editing as questions during the fellowship interviews. I'm just letting everyone know who's potentially interviewing for a retina fellowship. This is going to be mandatory.
I always feel weird when I'm on these calls where you have the practice run, where it's basically just, do you know how to share your PowerPoint? You have to log on a separate day at a different time. Maybe we need that in COBRA.
Is everybody else's screen going crazy right now? Or is this all Jared? Okay, there you go.
It's all Jared. It's all Jared. There you go. It's nice to see the technology in San Francisco and Palo Alto is very similar.
We're at the heart of this is Silicon freaking Valley, dude. This is
all right, Jared, take it away.
All right. So I'm Jared Sokol again, one of the first year fellows at Stanford. And I just want to present my case titled First Time for Everything. And my mentors on this were Dr. Rahimi, Dr. Pan, and Dr. Muthranjaya. So this is a 54-year-old female who was referred for a retinal lesion of her right eye. She endorses flashes and floaters for 3 weeks in that right eye and denies any headaches or neurological symptoms. She has a history of diabetes with an A1C of 7.3, hypertension, and hyperlipidemia. So on her initial examination, her vision was 20/40, pinhole 20/25 in the right eye and 20/20 in the left eye. IOP and pupils were normal. For anterior segment exam, it was unremarkable except for RBCs in her vitreous in her right eye. So here is her right eye optos on her initial presentation. So we have this large kind of white and red gliotic mass supratemporally with overlying vitreous hemorrhage and pre-retinal hemorrhage. And then adjacent to it more nasally, we have these areas of what seem to be neovascularization and a small area of pre-retinal heme. And we also have some medial opacity due to vitreous hemorrhage as well. This is just a TopCon color fundus color photo of the lesion as well. So you can see this kind of white gliotic mass with heme overlying and these nice lacy neovascular vessels with some pre-retinal hemorrhage temporally. And you could appreciate maybe a saccular nature to some of these aspects of the blood. So on OCT, her OCT MAC was normal other than RBCs floating around in the vitreous. You could argue her retina looks a little thin here, but I think that's actually just the imaging modality. For her FA, she had blockage of the lesion supratemporally. Additionally, she had leakage in areas most prominently here supranasally, but also some leakage on the borders of this area of venous non-perfusion. And it was also thought that on late images, she also had some saccular pooling in areas of the lesion that kind of corresponded to those saccules on the fundus photography. So based on all this, we had diagnosed her with a cavernous hemangioma of the retina with secondary non-perfusion with segmental NV leading to vitreous hemorrhage. So over the course of months and even years, she got worked up for this just to make sure she didn't have any central nervous system vascular malformations. She got an MRI orbits and MRI head that was normal, no hemangioblastomas or signs of VHL. She got a Avastin in the right eye, PRP in the right eye of the lesion and the NV overlying. But despite this, had recurrent vitreous hemorrhage and developed CME. She then received Ketalog and Ozurdex for the CME, which improved the CME. But then she developed an ERM that was worsening and her vision became 20/50 and she became more symptomatic. So here is her OCT May 2022 with CME calm, but she is starting to develop an epiretinal membrane. This is at the macula and this is inferiorly. She has this very thick kind of multi-layered epiretinal membrane. And then this is the most recent follow-up before surgery. She had developed 20/50 vision in the right eye with thickening of the epiretinal membrane, thickening of the retina and distortion of the foveal contour. And then inferiorly, this kind of large membrane, multi-layered area was just getting very thick, almost as thick as the retina. So this was her pre-op optos photo. We can still see some medial opacity from old vitreous hemorrhage. There is an ERM. It's a little hard to appreciate the details of the macula. Nasally, she has some pre-retinal membranous proliferation with actually kind of a focal TRD there. And then superiorly, you can see the old laser scars with really nice regression of that lesion. So our surgical plan was a 25 gauge vitrectomy, membrane PL with ERM, ILM, and some of that nasal peripheral membrane to try to relieve some of the traction on that nasal TRD and endo laser. So I'm going to just get going with the video here.
So hey, Jared, tell me where this is in your training. Where are you when you started doing this case?
What was this, Dr. Muthandjaya? Week 2.
So you're feeling great. You're ready to rock.
Yeah, this was my first, I think, VR case with Dr. Muthandjaya.
So you have your program director, even better.
Yeah.
How, like, can you, as you play the video, maybe talk about how you prepped for this? What'd you do to get ready for the?
Here, I'll just start. Yeah. I think, my initial prep was just going over the imaging. I like to kind of put everything in a Word document. I do want to touch on a small issue I was having there in a second, but I like to just pull the Optos photos and the OCT into a Word document with just a few lines about the patient, just so it's right there, so you're not struggling in the OR to pull up imaging. I think that this was kind of an irregular case. I'd never operated on what was thought to be a cavernous hemangioma. So reading up a little bit about that and seeing if anyone else had done anything like this before. And then, I don't know, I think just trying to stay calm and know that I'll be led through this with a good leader and graduated kind of learning.
The physical plan was ERM, ILM peel. Was it if the ILM comes, great, or if you move the ERM, you stay in there till ILM, you're still going to go back there and peel the ILM?
I think it was if the ILM comes, great. It was an ERM peel. Yeah, we wanted to get those big membranes off inferiorly, and if it came, great. If not, no. But I think given the nasal proliferation too, getting the ILM may be good to kind of remove that scaffold, just because this is definitely an eye that is tending towards developing membranes and fibrous proliferation more than just a classic PVD ERM kind of. Yeah.
Jared, it's great. You're pre-planning. Let's make sure you can safely get into the eye to see what's going to happen, because you can play it here, but I got some concerns about how all these trocars are going in, and it sounds like you want to focus on this too. So tell us, like, what did you encounter here with this first placement? Because I think we even had a COBRA on this last year. When that eye starts really torquing to an extreme, you got to be careful, because next thing you know, you might be through the lens.
Exactly. I think in residency, I always use a bishop to stabilize the eye, but I was trying a Q-tip, which I hadn't done as much previously. And I think that just didn't give me as much stability as I was used to. I think this sclera was also kind of thicker, and it was just difficult to get in. So I really had to kind of rotate and push, but trying as hard as possible not to let it torque in and hit the lens.
Pause there. Pause. All right. So I have a question. Once you get to second year, you pick up on these things, but pay attention, like for all the aspiring fellows, we try to perform a little bit of cosmetic retina surgery, if you will. Try to avoid those big blood vessels when you're going in, lest you pull out the trocar at the end. That's when you get like a huge hemorrhage and you lose your wound and you can get blood leaking into the eye. Go ahead. I want you to compare. What do you think about the placement of this trocar versus the subsequent one?
You mean the infusion based and the nasal?
No, this one with what's coming, because to me, it looks different when you do the next one.
So that's definitely more superior.
Well, more in terms of the distance from the limbus. I feel like you're going to get a nice shot where you can stop. Yeah. I mean, I think you're probably skirting right at 4 millimeters, but it's just a reminder to all of us, like, it's the beginning of the year. It's like back to basics. I've had this happen to me in fellowship where I went a little bit too far. Next thing you know, you're dealing with a retinal detachment in the surgery. But I even noticed when you marked it, you were just a little bit off from the limbus. So it's just a good reminder to all of us. Just like remark if you need to. I think
that's a really good point. And it's these things that actually make the surgery a lot easier, right? It's like how you place the head on the bed, so that how the wrist rests is, like where the trocars are, that can really make it easier. When I operate with first year fellows, even if things generally look okay, if they're struggling and we end up switching, sometimes I'll switch and I'll be like, you must have been so uncomfortable here. And it's so much harder to do the things if these basics aren't really set up properly. So it's definitely worth spending a lot of time on making sure sort of trocars are in the right place, head is in the right position, just to make it easier to do the things you want to do as well.
What are your tricks if you just are pushing and twisting and it just won't go in?
So the fellows that operate with me know, like, I'm very anti-twisting, but I think it's something you learn over time. It's kind of like a Goldilocks thing. If you push slowly, then you start pushing harder. That's when you indent the eye and it torques and everything. Obviously, you don't want to just jam it in there either. It's something you get comfortable with over time. But all the fellows who operate with me know I don't twist. I can stabilize the eye and get it in there. And it's something you get more comfortable with over time. I know everybody has different feelings about twisting. I see Sunil smiling.
I think, I was going to say that all this has to, exactly what you said, Isan, I agree with you. It's counter. It's what your counter traction is. So you were so uncomfortable with your Q-tip on that, so if I was psychoanalyzing you, this was your first one with your PD, you had your Q-tip and you hadn't done it before, you only did it a few times and you weren't really comfortable with it. And as you said, you were used to one other way. So you were just uncomfortable with like getting counter. And if you can't get counter traction on this and it's a thick sclera, it's very hard because if you're doing it correctly, as Isan says, you go slow, then it's like you're pushing really, really hard. So I think you needed better counter, either a 0.12 that you're holding across or, you know, trying to find something that gives you that. And as Prithvi mentioned, grabbing the infusion cannula sometimes can be a good way to do this.
Great.
Just a tip, I mean, I think Kat mentioned, we both trained in the same fellowship at Wells. I think it was Regillo that harped on this, about having the head set up in the right place to optimize your peeling. So again, all the fellows who work with us know, and I think this is, pause for a second, because we're gonna talk about that too.
Yeah.
Is when you tape the forehead, I always tape starting from the side of the eye that we're gonna operate on. Then when you're pulling the tape over the forehead, you can kind of grab the brow and expand your exposure. But also I'm like literally exaggerating how hard I pull the head, and that gets the nasal bridge out of your way. Especially depending on your patient, you can have a very high nasal bridge. And I've seen a lot of fellows run into that problem, like their hand, like Kat said, becomes extremely uncomfortable trying to get the instrument around that. So it's one way to like push the bridge out of the way, is if you're really exaggerating how you tape their head and rotate it.
Does anyone not ever tape the head? I tape the head for everything. Like
Never, yeah.
Whether it's a buckle, whether it's under general or not, I always tape the head. It's because I don't want to forget it.
Always.
Yeah.
I've had patients buck under general. I've had some of the fellows tell me, oh, they're asleep. I've seen patients buck under general and like all sorts of stuff happens. They always get taped.
Yeah, I stopped taping head a while ago, so I don't do it, but it makes complete sense. I mean, I don't, you know, when a fellow does, I'm like, yeah, that makes sense. I also do my nasal cannula first to get the hand position correctly. I think that's really important. We do the one index, two index figure kind of, you know, I learned, you know, Kat talks about it really nicely for our fellows about how to place that first one. And I think that sets you up for the temporal one really nicely.
So Jared, what happened here?
So this was actually part of a study. We were doing a vitreous biopsy. And so the infusion cannula is in and on. The vitrector is hooked up to a 10 cc syringe, and we're just taking a small vitreous biopsy here. But I think we were expelling fluid slightly too quick, and we get this small choroidal there. So the same thing could happen if I started using the vitrector without turning the infusion on. So we would deflate the eye, and in that situation, stopping, turning on the infusion.
And we've all been there before, again, in training, but again, this is back to basics beginning of the year. It's just always important to remind the fellows, always check the infusion, make sure it's open. Prithvi, what are your feelings about doing a biopsy under like air? I've had some colleagues tell me they do it that way and you don't get any like globe collapse. I mean, is it contagious or not?
I like it under air now, especially in pseudophakic patients. I like here we weren't going for a diagnostic bit. We were just collecting about a cc for a research study. So I didn't feel like we needed to go to air. Kind of, you know, if you're not doing the full vid, it just gets in the way. But yeah, all right, Jared, keep going.
All right. So we're just going to kind of continue with the core here, taking some of these little fibrous membranes. We're going to put down some triamcinolone to check the status of the hyaloid. And the hyaloid was off. We didn't see anything attaching to the nerve or around the macula. And then we just want to kind of segment some of these small tractional bands towards where the old lesion was and where the old laser is. And then there's actually a small operculated hole there temporally that I went and just kind of took that operculum as well. Just, you know, I guess learning that in attached retina, being very close to the retina is okay if the vitrectomy port is away from the retina. We switched hands here, kind of continued segmenting some of these small membranes.
What's your pointy instrument, Prithvi, of choice?
Point back of a Q-tip.
Okay, that's what you're using. It looks like a depressor.
Then they can't see exactly what I'm pointing at, but they have to know because it doesn't have a a sharp tip.
I like the Wexels because I throw them at the fellow. That works out.
All
I'm sure
right.
Kim loves that.
And now we're putting down some blue dye here.
So how long do you wait for your brilliant blue dye?
So
before you aspirate?
we waited a full 2 minutes on this case. And I'm going to stop right there. We set a timer on the vitrector as well. So no cheating. And I think we really did get a beautiful stain here. So I think that's definitely from the just waiting. Yeah. So here we see a really nice stain here. We see the negative staining in the area of the ERM, and then the positive staining in the ILM area as well. So we switched here, and Dr. Muthanjaya was helping me kind of get things going here. So he's going to go in with the flex loop.
Where are you thinking about initiating? Like, how do you do it, Jared? Are you
So we
looking at a
can
particular
critique.
quadrant or?
So honestly, that OCT inferiorly was super meaty. There was that, multi-layered fibrous area. And I think that was kind of a good spot. I think, inferiorly is superiorly is, I guess, more precious real estate in a way, because that's more of the reading vision. So I think maybe inferiorly is also a good idea to initiate there as well. Yeah. Any other tips?
Well, I'd say it's a little trickier to initiate superiorly because you're not the platform of your forceps. You're not necessarily seeing the direction that you're pulling, right? You're kind of pulling into something that's obstructed. So it's easier to initiate inferiorly and pull towards yourself if you need to.
Got it.
I agree. I think it's always easier, especially when you're starting and especially if you're doing like a pinch and peel technique, to be able to see your depth of pulling towards you rather than sort of pushing away. The other thing that I worry about in starting in some of these ERMs where there's these multi-layers of, I'm going to call it Danny Mamo's layer, there is sometimes you can get stuck where you think you have it all, but you don't have it all. So sometimes I like avoiding those areas to start, so I know I'm at the right plane, and then sort of ending up there where it's like very thickened.
Got it. And then we switch to the direct macular lens. So just, the inverter is not going on. We're directly looking at it. And so you have to focus down significantly when you get to this part. So Dr.
So is this Prithvi?
Yes, this is Prithvi getting things started, kind of raising up that inferior meaty edge we were talking about.
That looks so brutal.
Do
Yeah,
you guys worry about iatrogenic injury to the PM bundle? I try to avoid doing anything in that area. I mean, you're close to, you're not in it, but I'm curious what you think.
That's how Prithvi
couple
ensures
strikes
his.
there.
Yeah,
There are a couple
ensures
strikes where you
good.
saw the RPE like whitening that gave me a little.
Everything was under control, Carolyn. Everything was under control.
Do you feel you feel more comfortable being aggressive with a flex loop as opposed to like the Tano scraper? Or when you always initiating the peel?
I don't think we have Tano scrapers lying around anymore. I don't know if we're ordering it at the Byers. So I've been using the flex loop. I think I was trying to show him. That's why it looked right. I was trying to show him like what happens with kind of depth of pressure and then how it can get the whitening. But I feel like
you were showing him what not to do. I get it. Thank you. Thanks. That's really educational.
He was like,
That's
we're
great.
going to show this at COBRA. I'm going to bring him to teach.
That's how I teach over
It's
time.
brave. It's brave.
Yeah,
That's really good. Good for you.
He edited out the foveal hole that I made, but that's okay. That's good.
So then Dr. M was like, let's go. So I didn't really expect to be in the driver's seat now, but
I'm curious, Prithvi, if you normally start with a flex loop or if you do that while your fellows are sort of learning how to
So I would have, if I had a Tano scraper, I'd start with a Tano scraper. So as much as I think the fellows kind of gauge their ability of like, can I pinch and peel? I think for me, it's being able to, get the broadest area, open, and then going for the forcep. I don't try to do everything with the flex loop, but I think it's just my style. Like I like to be able to have that available, bring up multiple edges. I think it's just another technique to use because then you can use that for other areas as well. So I tend not to go straight to pinch and peel. Maybe I'm not that good.
I don't know what for the others, we're pretty big fans. I'm a big fan of the Hassan Tornabi macular lens, like with those foot plates. I find that you really don't need an assistant then to keep centering it for you. Like the fellows I think that operated with us really like it too. I don't know if anybody else has experience using that one.
Yeah, it's nice. It's designed for the the valve cannulas. It works pretty well. Okay, we're coming up on some time here, so maybe we'll show Jared in the seat.
So I'm just taking extreme care to watch my instruments go back all the way, just to make sure I don't run into anything. And Dr. M is actually having me just kind of practice opening and closing the forceps in the eye and just kind of strumming the membrane, touching the membrane, grabbing and releasing the membrane before we start doing anything.
I really liked how you made sure you knew where you were. I think it's a very different view than we're used to, just under sort of a wide angle. So really sort of seeing your instruments before you mag, and I think is really helpful, because otherwise you can sort of hit the retina peripherally without realizing if you don't see your instrument. I really thought that was good.
And I think you told me, like, if things get very bright, then you got to come out. Like, so I'm just working that edge a little bit, coming around slowly and carefully.
I made him kept like opening and going to another location. I think he was getting annoyed with me by now. It's like, can I just peel it off?
This is beautiful. It's coming off in one sheet. I mean, this is sometimes an opportunity. I think I steal the thunder from the fellows. They want to peel it off, but you can stop and get your cutter under that and just finish it. You can get the cutter, aspirate, and it all comes off really nicely. I know the Barricals are pretty fond of doing that, I think.
And that edge kind of frayed a little bit, so I just went to a different area. And it really is just one big, nice sheet.
Nice job.
So, what did we talk about when you're coming over the fovea?
So the eye is a bowl, and you know, to respect that when you're coming back out of the fovea, you need to come up a little bit. That is your low point. And I think, you know, always getting the lens, and that may be asking your assistant to help. So you're visualizing where you're going, not like where you're coming from. Because I feel like it's easy. It's such a small field of view. It's very easy for it to kind of go out of view and you be working on your edge and it's like, oh, I'm almost there, but you should really refocus. And there it comes.
Beautiful, beautiful.
And then we focus on it, and Dr. M's like, wait, pull it out.
Jared's just like, I just want to stay here for forever. I'm peeling in my second week with my program director. I just want to stay here at this moment a little longer.
And we go get it. This isn't in the greatest focus, but there he is.
It's a boy.
Yes.
What did you guys do with that nasal thing, the nasal area?
We went after it a bit. We just cleared all the vitreous on top of it, and we did go after it a bit with the ILM forceps, trying to peel, and we were able to peel, and it did relax. Yeah.
So Jared, you get the last word here. Tell us what were like the biggest takeaways from doing this. Like, what would you do different? Would you do it again, or being forced in the chair like that?
Honestly, I think being forced in the chair made it, in a way, easier because I just wasn't expecting it. I think that if you 2 days before were to be like, that's your first peel, I would have, I don't know, I feel like it would have made it almost harder. But I think, just always, I think following, in a situation where I'm really a novice at it, I'm doing something I haven't done before, just really respecting the person teaching you. And if they say stop, just stop. I feel like often you just, I don't know, you want to try one more time, but if I think just really listening to directions is important. And let's see what else. I think, I think for the port entry, I mean, I didn't like that part of the case. I think maybe either using the instrument I'm comfortable with or just saying, wait, how do you stabilize again? Like, how do you do that smoothly? I think is important. Yeah.
Awesome. Great job.
Thank you. Yes.
Good work. And
Doing well.
patient looks like it's doing well, which is the most important thing, right?
Yes.
Good job.
Thank you all.
All right. Good job, Prithvi. You didn't. I wanted to see a real-time measure of your blood pressure. That looks good.
I have my macular peeling tip video coming up soon. Obviously, it's going to be very popular.
All right.
Scraping everything.
This is why you're a tumor specialist. Thank you. Going to introduce Rachel Downs. Rachel is one of our first-year fellows. Rachel did her medical school at NYU and did her residency here at Cole. She is going to take it away, and I think our faculty advisor is Kat Talcott. Take it away, Rachel.
Thanks for having me. We'll see if I do any better, maybe even worse than Jared on the sharing piece. So I'm going to share my screen.
Come on, Rachel. Don't make me look bad here.
Did Hadi give you his laptop before he left as a
no, but it's not going well so far. Hang on.
Oh. Let's hope Hadi didn't pass along his video editing software, whatever he was using.
Okay. Okay. It's making
trouble.
Yeah, I'm gonna have to close out of Zoom to be able to share my screen is what it's telling me. So
Oh wow, fun times.
Okay.
All right, we'll see you right back.
What?
Maybe we'll go. Why don't we go to second years? Oh, you want to do that? So we do that,
perfect.
and then
yeah,
and then we'll go. So why don't we do the Stanford second year, and then we'll come back and do the Cole people back to back. Does that sound
Cole
good?
to take it through. That sounds great. So our second year fellow today is Dr. Austin Knapp. Austin is joining us from the Cole Eye Institute, where she did her residency, and she's doing a fantastic job navigating the world of senior fellow, which means that she bosses around people like Jared all the time. So it's good.
All right, let's see if I can do this better. Okay.
Hey, we're working. Nice job.
Second year fellows
Okay.
for the win.
Second year fellows.
Amazing.
Like
I've
crushing
learned
it.
something in 12 months. Hopefully a little more than that. Okay, so my case today is an awesome case I did with Dr. Rahimi on call one Sunday, like maybe 2 months ago. So I learned a lot in this case, did a lot that I didn't think I could do. So I'll show you the video here in a second. So this is a 52-year-old guy with a history of acute retinal necrosis, like 1.5 months earlier. And then of course we get the call on Friday afternoon with the Optos, photo in the text chat that says, uh-oh, he had a curtain in his vision. And now he has a retinal detachment involving the macula. So this is kind of his course beforehand. It'll come into play a little bit if people want to talk about it, but he presented initially and he had an AC tap positive for VZV PCR. He was treated systemically with Valtrex 2 grams 3 times a day. And he has been on this since initiation 1.5 months prior and is still on it when he comes to us with his detachment. He got 1 injection of intravitreal ganciclovir at presentation, and then he kind of refused any other injections after that. And then he was on like a oral prednisone taper 48 hours after starting systemic therapy, starting at 60 milligrams. He's currently on 20 milligrams when he comes to us as well. So his vision is 2200, his pressure is 8 in that left eye. He is phakic and he does have some vitreous cells. And this is an Optos photo of what that left eye looks like. You can see, and this is all we have. We haven't seen him. He was from, kind of far away, seen at like a satellite clinic. And this is kind of what we have to go on surgical planning, etc. So we can see, superiorly, at least his retina looks pretty ratty. He has, several holes and some areas of atrophy peripherally as well. Although the posterior pole here, I mean, you can see there's some, probably PVR and membrane starting. It doesn't look all that bad. And then I'll show you what ends up happening. This is the OCT. We can see, here a little bit better that he does have this kind of like thick membrane and PVR in the macula at this point as well. So we consent him for everything because we're not sure how it's going to go. We're planning and thinking on doing a buccal bit and then kind of, membrane peel, get off everything we can, see what happens. So let me show you the video here.
So Neil, you mentioned you ramp up their steroids pre-op. Like, what are you doing?
I think sometimes these come on call and you don't have time for it. So I just make sure they're on like 60 of prednisone post-operatively because they get a significant inflammatory reaction. So if you have the luxury of putting them on 60 of pred or a decent amount of prednisone a couple of days before, it will help you. But oftentimes you're doing it on Saturday, you saw on Friday, you get a day in, it's not going to make that much of a difference. So post-operatively, it makes a difference.
Do you do like IV Solu-Medrol like during the case?
I tend not to, just because, I'll do it in some cases. If you're in an OR that's comfortable doing it, sure. If you're not in an OR, if they're looking for the Solu-Medrol, you're not sure what they're going to give, don't even bother with it. Just put them on prednisone afterwards.
Okay. So this is our case. We did the buccal under direct visualization. And just to spare us, this is what we did a 4170 and we already tied down the buccal. We didn't tighten it all the way, but we, kind of had everything ready to go at this point. And then trocar, I didn't have as much, I didn't have conch to worry about, Jared, or any big.
So I'd make one point. If you just go back to the trocar entry, is someone helping you hold the strings right now? Is Asan like just, is he chatting or is he helping you?
No, I'm there. I'm holding. I don't think they noticed. But like,
so that makes a big difference, especially when the eyes open and you've got a buckle or the muscles looped. When you're trying to go in, you're like, oh, I'll just, it's easy now because the eye is open. It's actually harder because the eye is moving everywhere. So that's where your assistant, helps to kind of give you the counter traction you need. Otherwise, you can hit the lens even when the eye is all open like that.
That's a great point by Prithvi. It's actually when you're doing your supranasal, supratemporal, if you're doing it by yourself, you should pull on the opposite sides horizontal, your silk suture. That gives you your counter traction you need to do it if you're operating solo.
Yeah, I think that's
like
really nice. And then, it also, sometimes it can get confusing where you are. So it just allows you to keep your orientation a little bit better. If you know which one you're grabbing, it just allows for better counter traction, as Asan mentioned. Like we trained at the same place, Asan.
Same things. Austin, what's going on here? Because this looks crazy.
So when we go in, we're kind of, surprised, but not too surprised that the retina looks a lot worse than what we were expecting, which is why I'm like showing a little bit more of the just regular vitrectomy. We do a core and now we're kind of doing our peripheral shave, and we kind of notice like 360 degrees. There's just completely like necrotic retina and just pathology everywhere. And even like in the posterior pole here, after staining with triessence, like the amount of PVR here from when the Optos was taken, which was only 2 days prior, was significantly worse, which, was kind of surprising to us how bad this was. So I guess my sort of like, I didn't know I could do this, or, one of the things I haven't really done that much of at this point is peeling, PVR and ILM on the macula in detached retina. So that's what I'm doing here. So we stained with blue also the full 2 minutes, and I was having a hard time initiating a flap with the forceps. So I used a flex loop to try to get, a small edge or something that I could grasp. And I was able to do that. It is kind of challenging with, it detached, just even knowing where the normal anatomy is and like knowing where the fovea is. And trying to, keep that in the back of my mind as I'm peeling, and like the tension I'm pulling on the retina. And Dr. Rahimi was very patient and helpful in this case. But yeah, our goal is to peel as much as possible from the posterior pole and peel ILM as well if we're able. So we were able to peel a lot from the macula, and you can see it's a lot flatter now. And we were able to peel ILM as well. And now we're trying to peel as far out as we can. It's a little sped up, so it looks a little more.
So,
good,
couple
Yeah.
questions here. So that retina is really floppy underneath you. Did you
Yeah.
consider other ways to stabilize? You're using, so one question. Number two, peeling under PFO. Number three, as you're going more peripheral, I see you're still using the ILM forcep and you didn't switch to something heavier. So can you talk us through your instrumentation at this point?
So I think someone mentioned the use of a green lens earlier. So we switched to that here, like once we got outside of the macula, so that we could further visualize, because you're getting to the extent of good visualization with the drop-on lens. And I actually really like the green lens in this situation, kind of for this mid-peripheral area peeling and having good magnification. We do actually put a little PFO down. I think we were still like the membranes were still pretty extensive, like posteriorly into the macula. So we were trying to hold off on peeling under PFO because we felt like we were getting, a good peel in a decent amount of time. But that would be an option if we were really, really struggling. I think this part I was just kind of showing like there were some parts that were so adherent, we couldn't get it off, and we do put PFO down to kind of give ourselves counter traction as well. I guess you could always consider going, by manual too in this area, like maybe getting a pick like in that one little spot and seeing if you could elevate it. But we didn't really, that was kind of the only area we were struggling with, and we didn't really know if it was necessary to, we thought we had it all, and then there's just still even more. So we put down some more PFO, and we make the decision that we're just going to kind of segment that area because we make a little kind of a iatrogenic break next to that area. So we're just going to segment and trim it down and leave
How
it.
about putting some, did you consider putting down some blue?
Oh, you mean like restaining?
Especially for these peripheral membranes, like, I don't know, I'm kind of like buying into it. Like especially for PVR in the periphery, you got the PFO down. Like you can really sometimes see this distinction between, where membrane is and isn't, and that can be kind of a place to go to. And others on the chat, I think, will talk about how it changes consistency, etc. But for me, it's like I just want to see it. If I can see it, then I got to get it off. That's there. But I don't know your thoughts on that, and if others on the panel have used blue in the periphery for PVR.
I haven't used it that much, so specifically in the periphery. So I'm not sure if I know ASON, we use it a lot, but
yeah, I'm still a ICG catalog kind of person. So that's what I use, and it works pretty nicely for me. I can see the point of blue. I think it makes, we're staining membranes, so whatever you can do to see it, and I think it makes a difference. But I'll use green and catalog mainly. That's what I use.
Yeah, I'm with you. I'm a big stainer for peripheral stuff, but I haven't used blue quite as much. But looking at the chat, there's definitely a lot of people who are using it. Peter mentioned sort of refluxing it from the retractor is a nice way to doing it, or sort of after air putting it in. So, I think it's a technique that's being definitely used a lot more commonly to be able to see planes better.
Part of our hesitancy in this video isn't showing it, or you'll see it at some point, is that peripheral retina is like completely necrotic. And we're just going to start creating iatrogenic breaks. And at some point you see that we just start cutting everything. So it's just like, I don't think it's the great case to do that, honestly, but I definitely think there's a role for it.
You have to be careful because, as I said in the chat, some of this you have to look at the initial necrosis and get an idea where it is, so to stop peeling at that point, because you'll just rip the retina. As you said, Isan, so yeah, at that point you're just making more problems. I also find like using a diamond, in my mind, diamond dusted in these cases can be really nice to like find that subtle edge on these ARN cases.
I feel like the pre-op photo for this was very deceiving because it did not look
Yes,
mean,
that's why
the
you have to go to
detachment
the,
was-
yeah, you have to go to the
detachment was- yeah.
original arm
Right.
pictures, like when they are fully active and they look
Right.
miserable, and you start to see it, like, or the second picture when they start to pigment, like that's the picture you want to see, not the detached picture, but that picture. Then you're like, okay, this is where the necrosis edge is. I know these are the thin areas. That's what I should look at. But it's an Optos photo, so it's all screwed up anyway. But
Yeah, the
use
picture,
it
the
to- for
colors
example.
are terrible. Yeah.
So Austin, you know, Asan was talking about, you know, you need to, at what point to stop? Like, were you like ready to stop now, or you were like, I'm going? Like, it's like, and how do you come to that decision point now as a second year?
I mean, I think as soon as we entered the eye and were able to see the extent of necrosis and, you know, that it actually in some parts extended pretty posteriorly, we knew in our minds that we were going to have to cut a significant amount. I was trying, you know, my goal was definitely to clear the macula, clear as much, you know, in the posterior pole that I can, and try to bring up as much as I, you know, could anteriorly to around the edge, you know, where we were going to cut. But, you know, at this point in particular, it seemed like it was more risk, you know, it wasn't safe to continue trying to peel that area. And it was just easier to cut it down and segment it and relieve the traction in that area. So that was my goal and kind of what I was thinking at this point.
Okay.
And then
These are hard. Like these cases, arm detachments in young patients, you're a great surgeon. These cases make you feel like a crappy surgeon, because no matter what you do, there are going to be breaks. So you have to be ready to do exactly what you're doing. So you're doing a fantastic job. This is really intelligent what you're doing. So great decision making, which is the most important thing here.
So now we're just, you know, we knew we had to cut a lot. We're trying to incorporate, you know, all the breaks that we're finding and trying not to leave any, you know, sharp edges where some of the breaks kind of extend more posteriorly, and trying to leave him with some retina if possible. We do leave him, I'll show you, with one little, you know, a couple clock hours superiorly that was still attached and no pathology. And but otherwise we cut pretty much 340 degrees.
Yeah, so that 20 degrees, I would often try to save that when I was first in the business. Now I don't really save it. It's good to go. One thing, and it could have just been the light, but when you're on the nasal side doing your diathermy, initially, like the inferior diathermy was like, you know, nice and point, but it was like pretty bold over there. That just could be the light. So I'm also a heavy diathermizer, like when I'm doing this, but you can get a little bit of kind of folding of the edges. It can kind of claw back a little bit. So, and it's hard to sometimes tell exactly what needs to be lasered after that. So again, judicious diathermy, but maybe not like confluent, super, super thick. You can get that with laser.
Great point. And Dr. Rahimi, you know, there's always those voices you hear in your mind. And after diathermy, he always, no matter the situation, he's always reminding us, diathermy is not laser, diathermy is not laser. Laser where the diathermy is not laser. So
nice.
Daniil, last year we had one of these types of cases that came up. What are you doing with that buckle? So I also kind of set you guys up in the beginning.
Yeah, you know, I think once you go 360, you don't have to keep it. You can take it off. I mean, I think that makes sense. The other thing you have to remember here now is anterior. You got to make sure you peel everything anteriorly, because hypotony in these eyes is incredible high risk because of anterior PVR. So I'd use the buckle to my favor and pull it up a little bit so I can do that anterior trim, and then I'd probably take it off.
Yeah, I mean, we were debating going back and forth of what we should do with the buckle. We already, like I said,
you don't lose anything by keeping it.
Yeah,
I mean,
we already tied it down, and
I did all this work.
We
I
left
think part of it is psychological for the patient too. That's why ultimately we left it. Is this guy was read the riot act beforehand, like you are very likely going to redetach. We need to throw the kitchen sink at your eye. I think if we took it off and then he eventually detaches anyway, which you know is a very high risk. I just imagine if I was a patient, I was like, you shouldn't have taken off that buckle, kind of a thing. Even though I think we all know it's not doing anything.
I think it's more than appropriate to keep it on. I think you've been fine either way, but like, I think if you, that 20 degrees, man, it's helping those 20 degrees.
I think it's good though. It's nice to say to the patients, like, we did everything for you, especially if they've been led to believe they need a buckle for some reason. Then if I don't put them on, the patient's always like, why did you put on a buckle? And that's always in the back of their mind. Like, if I reattach, you're going to put on the buckle. And it's harder to explain. Well, I actually cut, 360 of your retina. So, so I agree. I think it's great.
I'm just showing this part because it's something that we like to do if we use PFO. I didn't show here, but we did a BSS rinse to try to get the PFO out, but especially because we knew we were going to mess around with a buckle and do some other things before we went to oil. We just like to vent the PFO, so we'll put in the vent and increase the pressure to 50 or 60 and just leave it for 30 seconds, a minute, while we're doing whatever we're doing, and the high vapor pressure helps the any remaining PFO particles evaporate. So that's why we put in the vent at that point. Now we're going to leave oil. Is anyone not leaving oil in this situation? Okay. So
you can leave him air-filled. You can leave him air-filled. They'll be fine. They'll be fine.
Okay.
Why did you choose an air to oil exchange rather than a direct PFO silicone oil exchange?
I mean, we felt like when we were, going to air, the edges of the retinectomy, they weren't really moving. We didn't flip the retina. And then I don't know if that extra little part that we left helps
the 20%
translocation or not, but I guess you could also make that argument that maybe it helps, slippage and things like that as well. That's why.
There is a downside of the direct PFO oil exchange in these cases, I think, is that the optic nerve in ARN cases in ARN patients is incredibly sensitive. They have nerve disease. So the problem with the direct PFO oil exchange is the urine pressure does go up. That nerve starts to pulsate.
Mm-hmm.
So I think you put these eyes at higher risk for postoperative optic neuropathy. They're at risk of it no matter what, but it's a sick nerve. And I think doing that actually is worse for the patient. So this is the case I don't do it on. I do air fluids on these. I don't want the pressure to go up. So I'd actually say I would avoid it in this kind of case. I defended you there, Austin. I'm with you.
Thank you. And we did a intravitreal injection of ganciclovir at the end of the case as well. And then this is it. So let's see.
Wow.
So this is post-op week 2. Post-op week 2. His visions count fingers. His pressure's 13. You can see I'm really worried about this area inferiorly. I don't know if you can see my pointer or not, but we're not sure. It looks like it's PVR starting as well. We do have him on high dose PO prednisone. Is there anything else? I mean, would anyone be bold enough to do methotrexate in somebody like this, or?
Yeah, I mean, I think you just methotrexate. I know, but methotrexate in an ARN eye, the ARN is the key here. It's not, don't let the retinitis come back, especially again, the optic nerve version of this. So I wouldn't locally immune suppress this eye unless you push came to shove.
Mm-hmm. And now he has this nice little tiny macular hole as well. So.
Yep. This looks great though. And again, you've left enough real estate to go back and fight in that another day. And the superior part doesn't look that bad. I think you have good tissue there. It's just always the inferior. And I can see another little smile coming there, but it'll connect.
Do you think that the hole came from your peel? I mean, what do you think the hole showed up? I mean, I'm just being provocative here. I'm just asking, what do you think
I'm honestly not sure. We didn't really notice anything intraoperatively in terms of when we were peeling the macula, any trauma or iatrogenic, breaks or anything like that in the macula. And we felt like we peeled all the ILM, at least, definitely over the fovea, and pretty much arcade to arcade. So
I've seen it happen before of when you peel the ILM over in these detached that you can pop a hole, or it was there all along, right? So it's one of the, sometimes you don't know. So just look at your video. Sometimes you can see it. You'll see it kind of pop open.
Very nice. That
Great
was a tough
case.
case. When was
Nice
this?
work.
End of first year or start of second?
I think it was the beginning of July.
Nice.
Yeah,
Nice job attending. Good work getting her through that. That's awesome.
Awesome. You did great.
Thanks, Dr. Rahimi.
Passing it back to Cleveland, Ohio.
All right, let's get back into it. Rachel, are you up and ready?
Success. I think so.
All right.
So I'm going to share my screen, attempt to. All right, so things are already going better.
Woohoo.
Looks good, Rachel.
Okay, so I'm going to be presenting my first TRD, which was during my 3rd week of fellowship a couple weeks back now with Dr. Yoon. So our patient was a 44-year-old woman who was referred initially in the fall of 2022 from an outside practice in town for management of PDR both eyes. She had had recent intravitreal injections of Avastin in both eyes and had sort of had spotty follow-up at that site over the years. She tells us that her vision has worsened over the past year, with the right eye having been the stronger eye until pretty recently. On initial presentation to us, her vision was unfortunately count fingers in both eyes. Pressures were 8 and 11. So this is a fundus photo of the right eye. So significant tractional, excuse me, membranes here, some pre-retinal heme. And the fovea was detached in this right eye, which was previously her stronger eye. And here is the left eye. Again, really significant traction encircling the macula there. So on presentation, her A1C was around 14. There was a plan initially for like really prompt surgery in the right eye, but they were unable to proceed with that operation as scheduled due to high blood glucose and pre-op. She was lost to follow-up for a few months after that. Eventually, we were able to set her up with a primary care doctor. She got on a better regimen for her diabetes control and had regular follow-up with ophthalmology in the ensuing months, with continued treatment with intravitreal Avastin. So about 2 months before I met the patient, she underwent cataract surgery, vitrectomy, membrane peel retinectomy, PFO, endolaser, air fluid exchange, and silicone oil in the right eye, with a resultant vision of 2400 at post-op month 2. And the patient was really happy with this improvement, felt like it really improved her functional status, and was eager to proceed with surgery of the left eye. So that was my case. So I'll show the video.
Thanks so much, Rachel. So what a cool opportunity to be able to do sort of a complex case, or at least parts of a complex case sort of early during fellowship. Tell me a little bit about, since, you know, you probably were anticipating you might get to do some things you hadn't done before. Did you talk to Dr. Yoon sort of before about what you might be able to do? How did you prepare, and sort of what things were sort of going through your head of how you would sort of maximize that opportunity in the eye?
Yeah, so Dr. Yoon gave me the advice of not just thinking about the steps that we might do, but actually the specific instruments that I could potentially use to do them. So before the case, I wrote out like every step of the surgery that I thought we would do. And then within that, like all the different variations of technique and all the different possible instruments that we could use for each of those steps. And then we met the morning of surgery and went through everything together, and then went back and physically pulled everything that we thought we might want to use so that I could sort of see their instruments and familiarize myself with them a little bit more. And then other little things, I drew myself diagrams of the petals the night before and made sure that I had a good sense of everything I would need to know.
So I feel like this is so important for making your attendings feel very confident in you. I think Rachel did an extraordinary job with really making sure she was well prepared. She studied everything from the patient to, the room setup, the pedals, which is, I think, one of the most important things when you first step foot in the OR, know how to operate the pedals, know exactly what each button does.
Thank you.
Yeah, I think all of that stuff goes a long way, as sort of we're seeing in the chat, but sort of spending that time on your end, and then, communicating that to your attending that you're taking this case and this opportunity seriously. I think that only leads you to make, to probably be able to do more during the surgery, but to do more successfully since you've sort of prepared. So show us a little bit about what happened inside the eye, since I think we nitpicked everyone's trocar placement in the first hour of COBRA.
So a cataract surgery was obviously done at the time of this by one of our excellent residents. So we can see she sat superiorly. There's our main wound, and I'll quickly go through the trocar placement here.
Shout out to the BNL system.
Yeah, yep.
I like doing phaco's for these cases too. I think it makes it a lot easier to be able to access things, and I think just gives you a more, just better visualization during the surgery too.
There we go. Skipping ahead to the good stuff inside the eye.
Ooh, lots of good stuff there.
Yeah. So started out with a left-handed technique, and then quickly felt like I wasn't making much progress, really digging into that membrane. Once I had my lighting better here in a second, I can see that I actually did start to create a hole there. But at any rate, switched to my right hand and sort of found the edge of that membrane and started dissecting from posterior to anterior. And then took that as far anteriorly as I could go before trying to move inferiorly and extending that plane that we had found.
Is anyone preemptively thinking about needing a chandelier in these types of cases, or you just kind of see it as you go?
I think
So
that's
as
a
part of
good
the instruments
point.
that were pulled, it was a chandelier, but we didn't end up needing it actually for this case.
I usually ask them to have it available sort of in the room for these types of cases. And then I sort of start and do what I can. I'm a big fan of doing like a 23 gauge setup, and using like a 27 gauge cutter, I think is really nice, especially for sort of early in fellowship. I think it's an instrument people feel comfortable with using, and kind of allows you to get in the right spaces without being too traumatic. I feel like the lighted pick is sometimes a little harder at the beginning, but I think it's, as Rachel mentioned, just good to have lots of things available to switch over if you want to. Prithvi asked you, Asan, if you would think about having just put in a chandelier at the beginning. Sorry.
Yeah, I think in the beginning, if it's like, something new for the fellows, just to do it, just to get comfortable with the idea that it exists and how to put it in. I agree though, I don't think you necessarily need it here, but I'm like you guys, I just have them pull it and be available in the room, so it's not wasting time if we end up thinking we need it.
Mm-hmm. I like the variety of pointers that we're seeing by the attendings here. Is that a depressor, Alex? What is that?
It was a Drysdale.
It's a bent Drysdale.
Yeah. Kind of bent Drysdale for Metro. So one of the things we talked a lot about, which I did like a moment ago in the video, was the importance of maintaining a really clear view during these cases. So once we identified that we had some active bleeding, we went in and quickly cauterized as soon as we saw it to try to keep things clear.
I think that's really good. I feel like I always sort of tell our fellows that like a lot of retina surgery is actually just visualization. If you can get a good view and keep a good view, like the actual technical parts of surgery are not as difficult. And I think that's really true for these types of cases. So I think things that you're doing here really nicely is making sure you have good illumination, the tissues in focus, and sort of, with Alex's help, sort of going after any hemorrhage that occurs so you can see those planes better, to be able to better get at them, and then for you to be able to stay in the surgeon chair.
So
how did you start deciding, Rachel, when you're done? Because there's so many membranes you could keep peeling.
Well, I guess we'll get to that in a little bit, but we started dissecting over here nasally, which I'm sort of like trying to feel it out with the cutter and understand exactly what I'm dealing with over here. There's a retinal fold here nasally as well that we wanted to make sure we weren't running into. Yeah, I'm not really sure. Dr. Yoon, do you have any thing to add about that?
So I think in these cases, we have to keep in mind, always have an exit strategy for TRDs. I think trying to get all the membranes off the macula is, certainly my goal. If there's still tractional membranes in the periphery, especially nasal, I'm less aggressive with those.
Hey, go back to this point here. Is this you, Rachel, peeling Pulling the
So
plug?
this is the one part that I didn't do. So when I realized that I wasn't really comfortable or confident going with my cutter because of that retinal fold, we decided that we were going to use forceps. So I tried this once with my right hand and the angle just wasn't great. And so then we ended up switching. Dr. Yoon used a left-handed technique here to try to peel that membrane off the nerve.
So he didn't use the Prithvi, flex loop, whacking the retina method. Huh. Okay, good to know.
No, I didn't see
Strangle
that.
the retina.
This is back to me though. I realized this when Dr. Yoon and I were going over today. He switched to a Wexel pointer at this time. So then we decided that we were satisfied with everything posteriorly and moved on to the peripheral shave. And then this laser is in real time. So watching this back, I think I learned a lot about the laser techniques and the importance of sort of modulating the speed of your movement against the settings of the laser. So I feel like as I'm making this initial barricade, I'm moving at like an appropriate speed for my current laser settings and I'm getting good uptake. And then I decided that I wanted to be a little bit more efficient and in a second try to start moving a little bit more quickly and actually end up being less efficient because I'm not getting the uptake that I was looking for. So that was a nice learning point for me.
Yeah, it's hard. You want to go faster. You have to adjust your settings when you're moving your hand. That's all this is.
Mhm.
But that was really good laser for at your stage. That was amazing. And Alex,
Yeah, I think that's
kick
really
you
great
out.
laser. Exactly. Yeah, I think lasering as a beginning of fellowship is hard because I think you become aware that it's painful to watch yourself laser, and then it's sometimes it must feel painful to have the attending watch, your laser, but just making sure you're getting good spots, is more important and will save you time overall. Later on you'll be able to be sort of more efficient, but now the focus should just be on sort of good technique.
And then here,
Why'd you pull the
sorry.
Why'd you pull the cornea suture?
Oh, do you have a plan to pull that from the beginning of the case? I'm not totally sure. Dr. Yoon, why do you like to pull those?
A lot of times I do leave it in. I don't know. Really, for this case, it was something new I heard some of my colleagues were doing. So I'm like, you know what? I'm kind of sick of pulling these sutures in the clinic. So let's just try to pull this one.
I thought you were trying to bury it, and then you just pulled
Yeah.
it.
No, it was planned. It was
intention?
actually planned.
I usually pull them too at the end. Once I'm done with everything else, it's the last thing I'll do. I've actually started pulling them because I otherwise feel like I just stare at them forever in clinic, or have to be like, I have to go find a pair of jewelers that work, which always feels very painful in retina clinic. So I've started pulling them at the end too, but I wait until the rest of my trocars are out too. Nice job, Rachel. That was beautiful.
Thank you. So this patient's about a week and a half out from her surgery, so we don't have any post-op photos just yet, but her vision's hand motion, she has a good pressure of like 11 at this time, so we'll see how she does.
Retina win.
Awesome.
Nice job.
Yeah. And doing things with your left hand. Congratulations.
Thanks.
Good work. That was amazing to do at this stage. Obviously, the expectation is not, no one's expecting everyone here at even month 6 to do a complicated case like this. It's if you can accomplish each goal and get through it, you can see how much you can get to do. So that's great. Good work. And incredible patience, Alex.
I think it was also really helpful, all the pre-op planning, not just what you thought of, but the months that you really getting good ideas, being compliant in clinic. I think if you had gone in originally, if you had something that it would have been a much more challenging case.
Even if you approach this case, Rachel, with this is where I'm going to make my first cuts across the macula, or I'm going to segment here and there, and that's all you got to do. At least you've kind of visualized it, and then you can actually attack the most obvious things. And I think that would be a good lesson for all fellows doing their first few TRD cases. Is just if you can even break that down into a packet, one packet, and you can say that I've done that, I think that's a win.
All right, let's end up with Jacob Cox. Jacob is our second-year fellow. Did his medical school at Johns Hopkins and residency at Mass Eye and Ear. and is going to show us one of his cases where he's learned a lot from, or didn't believe he could do something and did it. Go for it, Jacob.
All right. Hi,
Look at
everyone.
that alliteration.
It's the best title I could come up with. I'm sorry, everyone. I couldn't come up with anything wittier, but lots of seasons.
You get points. You get points. Good
tried.
job.
So yes, I'm Jacob Cox. I'm one of the second-year fellows here, and I'll be presenting the COBRA choroidal conundrum. So let me get this out of the way. So our patient is an 82-year-old female with Lewy body dementia who was referred to us for uveitis, hypotony, and a macula off retinal detachment in her right eye. Due to her
Already sounding like an amazing case.
Yeah, starting off strong. So due to the severity of her dementia, the chronicity of her detachment was unclear. But basically it came to people's attention because she has a power of attorney who about 5 days prior, she had told, I can't really see out of this right eye and it kind of hurts when I push on it. And so 1 day prior to seeing us, she had presented to an outside practice where she was diagnosed with uveitis, hypotony, and a retinal detachment. They started her on topical prednisolone and cyclopentolate and then referred to the Cleveland Clinic for further evaluation. Her past ocular history was notable for kind of borderline high myopia, a history of myopic LASIK, and then she had mild cataracts in both eyes. And past medical history, as we mentioned, she has Lewy body dementia, as well as a remote history of an intracranial hemorrhage, for which she had received a craniotomy. And so on our exam, she was count fingers in the affected eye. The pressure was 2, and she had 1+ AC cell and flare, as well as was mentioned, a mild cataract. And then the posterior exam was a bit challenging, just again, due to her dementia, she had trouble tolerating our exam, but we did identify 1+ vitreous cell, and then what looked to be kind of substantial choroidals, which we thought based on their appearance were likely hemorrhagic. They were non-kissing, but they were nasal, temporal, and inferior. And then we couldn't appreciate a break on exam, but we decided to get a B scan. The B scan showed 360-degree choroidals that were highest at 3 and 9, with that highest point being 6.9 millimeters. And then she was found to have a total retinal detachment in an area that was suspicious for a possible break at 2 o'clock.
And so Jacob, was the thought here is that she had an RD leading to a uveitic like picture, or that she might have some sort of underlying problem leading to an RD? And what did you think about the choroidals being sort of hemorrhagic and not sort of serious? Did that make you sort of think twice about anything?
So it did. And actually, I guess this is an abridged version of the story. She was originally seen at one of our satellites where some of our imaging options are a little less, they're just less. And so knowing that we would need to refer her to main campus anyway in a couple days to get further evaluation, and knowing that this most likely was not an acute process, we decided to say, we can't see a break. These look like hemorrhagic choroidals, which would be a little uncommon for a rhegmatogenous retinal detachment. Perhaps this is, especially with the cell, perhaps this is more of an exudative process. Let's start her on some systemic steroids and see how she does. And once we saw her at main campus a couple days later, we were able to get better imaging, which kind of elicited this this possible tear on B scan. And the detachment really hadn't improved at all, nor had her pressure or her cell on the oral steroids. So just given that, we felt like, okay, we were hoping that this was just exudative and would improve with steroids, but it wasn't the case. And so we decided to move forward with surgery.
How long was this choroidal there now for?
So that's a great question. We don't know. Again, the patient had reported vision loss and some pain 5 days prior to seeing us, but okay, with her advanced dementia, it's certainly possible that it could have been there longer.
This doesn't look terribly liquefied. I mean, I don't know if the dynamic ultrasound, you could see things moving around, but it's not solid for sure, but I'm not sure it's liquid either.
Yeah, and actually on the B scan, it was noted that she had these mildly mobile opacities within the choroidal space. So again, just kind of suggesting to us that this was more likely to be at least some sort of hemorrhagic choroidal rather than, say, a serous choroidal.
Jacob, any trauma that you guys know of? Is that in the back of your head with a dementia patient?
Yeah, she has a fantastic power of attorney who seems to be with her quite often. And we asked him that very question, has there been any trauma, fall, car accident, self-inflicted trauma? And he said there was nothing he was aware of. He hadn't noticed any bruising or marks to suggest that there'd been trauma he'd missed. And then we were also thinking, is she on any sort of anticoagulant or antiplatelet medication? And she had never been on any of those medications. So.
There's some interesting comments in the chat just with her pressure being 2 and sort of that could make the surgery a little bit more difficult. You know, obviously you tried her on systemic steroids, but would anyone consider any sort of local sort of steroids, or would, you know, systemic you feel like be enough to give you the try and get the pressure up? Just curious to hear other faculty members' opinions.
Yeah, I tend to use orals. I think perioculars take a little bit too long. Orals also you can control on and off. You know, so if you have an untoward reaction to steroids locally in the eye, like, you know, maybe this was, I'm not saying this was an infection, but something else was occurring, you can at least turn it off. With a periocular, I think it takes a week or 2 really to kind of get really up there. And I think oral steroids at the right dose usually will get, you know, really will get you control. And you'll know actually quite quickly because pain usually gets better if she is able to verbalize that.
And thinking about options for local steroids, so given the 360 choroidals, I think you would be limited to a sub-Tenon's Kenalog. Otherwise,
absolutely.
I don't have any other.
Yeah, and I think if you're planning on going on in this eye relatively soon, it's probably not going to kick in by the time you need it. So I would probably start with oral or Durezol for everybody.
Thank you. Good days.
So at this point,
right.
we've decided. Sorry, go ahead.
Oh no, go ahead, Jacob. I was just going to say, show us what you did.
Yeah, so at this point, we've decided to go in the eye. As you can tell already, we've placed a scleral buckle, anticipating that this is, you know, most likely a rhegmatogenous detachment. And with the hypotony and the plan to drain choroidals, we start by placing a Lewicki AC maintainer.
Is she under general anesthesia?
She is under
Dementia.
general anesthesia. It was thought that A, it was going to be a longer case, and B, her ability to kind of tolerate the surgery and stay still for us was just extremely unlikely.
Have you cinched up the buckle at this point, or is it just loose?
So we haven't cinched it up yet because we're planning to do our choroidal drainage, and we want to have a little bit of leeway to get around it as we do so. I was talking to Danny about our thoughts on this because I've heard different techniques for doing choroidal drainage. And typically he does them more anteriorly than we're doing them here. But with the suspicion that these could be hemorrhagic, it's his experience that hemorrhagic choroidals don't drain very well if the incision is made more anteriorly. So we kind of deliberately made these more posterior ones, obviously corresponding to the sites or the clock hours where the choroidal was found to be the most elevated.
Other thoughts? Would any other faculty members drain differently here? Would you have done like more anterior, or you agree staying more posterior for these hemorrhagic choroidals?
It's all connected space. I don't think you have to go posterior. And now the most controversial move in all of retina. It's coming. Dun, dun,
Do you
dun,
go
dun,
after?
dun.
So we actually decided against it.
Yeah.
As you
Just
could
tease
see,
It looked like you were going to go for it. It looked like
I
you
know,
were
it's
going to
like
go for it.
straight in.
It was like right there.
we
Okay, so-
exactly, we were kind of gearing up, and then just that outpouching of this sort of presumably choroidal tissue, we were like, I don't want to potentially manipulate that. And so we felt like we'd gotten a decent amount of drainage, and it wasn't looking as definitively hemorrhagic as we came into this case expecting. So given those factors, we said, you know, let's just hold off, and we've hopefully drained at least enough to get into the eye when we need to.
You know, Jacob, this shows really well that it's all connected. I mean, it wasn't very high, right? You know, so maybe the prednisone helped you preoperatively as well to get rid of some of this stuff. But when you see the choroid come right to your sclera that quickly, it tells you like, this is probably connected. So your second one, you probably could have gone anteriorly at this point, but it worked, right? You got to accomplish what you wanted to. It's all about being safe. That's all. That's why I like to go more anterior. That's just my experience.
More anteriorly than this. Okay.
I go like 4 millimeters back. I don't go much farther than that.
I see.
Anybody else here use the trocars? I'm a fan of using the trocars to drain the choroidal too in some cases.
A lot of discussion on that. Asan, what's your experience? Anytime that goes bad?
I haven't had it go bad. Have you guys had it go bad before?
No, I don't. I don't use it as much. I do the cut down more, mainly just to kind of show the technique. But any issues with like angulation or going through the retina or anything
I
like
think
that.
the key is preoperative planning. Know exactly where you're putting it in. Having good B-scan images. I'm trying to go in the thickest part of it. I'm like you guys though. I try to stay pretty anterior and angle it in so you're not going straight in. Obviously, last thing you want to do is end up going through retina, especially if you're far back.
Yeah, I haven't, I see people do it. I just am comfortable with my cut down, like just going partial thickness, that I think I can see the choroid and I can see the tissue. So there's a certain level of going with the trocar that I feel like I'm not seeing in where I'm going with that blade. But if you're comfortable doing it, I don't think it's, I think it's a great technique. I feel more comfortable just identifying it with the MVR blade. So that's why I do it this way, or why I do it that way.
Just for my learning, could I ask why it is you prefer to use the trocar? Do you feel like you get better drainage, or is it a quicker process?
Just speed, just efficiency. I mean, in terms of the case, I don't have any problem with cut down either. I don't think one's superior to the other. It's whatever is comfortable in your hands.
100% agree with that.
I like to have
different ways.
I like to have the ultrasound in the room as well, because sometimes you think you have enough drainage, but if you put a plastic cover on the probe, you can do a quick ultrasound and figure out like, oh, it's loculated, it didn't all drain. You can check the other quadrants and then know where to go next. Because sometimes you can't be sure you got it all, even though it looks like it was a lot until you go in. So this is another way to know.
To put an indirect on your head and look in.
Aha.
Very
old
tech.
school.
One of the advantages of doing a cut down is that wound stays open, and once you do your vit, you're going in the eye. I find sometimes when you put PFO in and you bring it up, it'll actually help you drain even more too through those wounds.
Nice.
All right,
show us.
Yes.
So that was our temporal sclerotomy for drainage, and we do the same on the nasal side. Because again, our choroidal was highest at 3 and 9, but really not much came out on this side, just a little bit. And then we talked about reasons to maybe go anteriorly. I think this is a good reason. As you can see, there's a not so mysterious jelly-like substance pooching out.
Interesting.
And so we decide to secure our scleral buckle directly over the sclerotomy and make sure our globe is reinflated prior to going in. Tighten our buckle a little extra so that once we're in the eye, we'll have some natural depression, basically. And then just with that history of choroidals, even though we've drained them, I went straight in with my trocars, and we did use a 6 millimeter infusion cannula. Here we're doing just our core and making sure that our hyaloid is up, which it was. And then do our peripheral shave. And here, this is that area, this corresponds to that area where we saw the jelly pooching out. And clearly there's a little bit of a retinal break there. So we're making sure we clean any potential vitreous off that area.
It looks like a well-placed drainage retinotomy to me.
Well, a well-placed drainage retinotomy that unfortunately gets a replay because you'll see the retina goes right to it.
That's beautiful. That's a great picture.
So now we're dealing with retinal incarceration, but we'll deal with that later. So we continue our peripheral shave and we find our causative break that corresponds with what we thought on the B scan. It's at 2 o'clock. And so now we're trying to release that, that incarcerated retina. And this is a technique that was described by Cindy Toth back, I think, in 2009, where you can use some viscoelastic through that sclerotomy site to release incarcerated retina. And sure enough, we're no longer incarcerated.
For now.
Fluorocarbon on the
That's really
inside
nice.
may have also pulled that out too. It's hard to know how deep it was, but PFO in the posterior pole could have helped release it, could have aspirated it, but that was very elegant.
Yeah. Well, so unfortunately, as elegant as it may have been, as the case moves along, it just it incarcerated again. So we feel like, okay, we can't rely on this thing to stay reliably unincarcerated. So let's do a relaxing retinotomy.
Would anyone have done anything differently here? Any other techniques that people have used, or would you have sort of cut earlier than they did?
I think perfluorine and then cut. That's what I would have done.
Yeah, I would have
So-
cut right away too with incarceration.
You could tell by the configuration of the retina, you're going to be cutting anyway in this case. So
Mhm.
cut early. Looks good.
It's a perfect drainage site. Good job. Good pick.
That was the intent, really.
So did you think of I don't know if you see it, but did you suture the drain site at this point, or you just buckled over it? Because there's the concern that there could be a connection, so PFO or whatever you put in could go out through that hole.
That's
I may have sutured it at this point. Normally I don't, but I may have sutured it. Peter Tang asking the same question.
We did discuss the option intraoperatively, and I think between the two of us, we felt like with the buckle sitting so well directly over the site that we were not going to suture it directly. But I think we could have. I think either way would have been a reasonable way to go. But we did not suture that sclerotomy directly.
Does everyone cut down completely to drain? I usually cut down partial and then drain with a needle to try to prevent this incarceration.
Yeah, I think there are multiple ways of doing it. I think if you thought it was as hemorrhagic as they did, I think that, I think I get the reason why I got cutting down with the blade to that point. But yeah, Alex, I think your technique is a technique that most do. Or many do. I don't want to say most, many do.
So despite our suspicion for kind of a chronic 360 detachment with, we expected some PVR, but the retina really flattened pretty nicely under PFO. And so at this point, we're obviously laser barricading both our original break that caused the detachment as well as the retinotomy site. And with the retinotomy where it is being so posterior, we just felt like the buckle wasn't supporting it as much as we would have liked. And so we decided to add a 112 meridional element as well. And I didn't have a lot of experience with these, so I don't know how many other people do, but it was just kind of interesting to go through placing this with Dr. Mamo.
Ritzy, when's the last time you put a 110 on, man?
In my dreams. No, it's been a while. But I also feel like at this point, you've relieved traction. It's, there's nothing there. It's a, localized circumferential retinotomy. You're probably A-okay. It's not right at the vitreous base. I understand why you're doing it, and it's all good, but I think you're okay at this point. You got the buckle there. I'm not sure I'd do all this. Maybe I'd put a stitch through that sclerotomy more than anything else.
I like it. I think it was, I think, extra support there. I've done these with just taking part of the 41 and just sticking it right in that and just putting it as a kind of almost like a, posteriorly oriented. But I think the 110, I think this works great.
Yeah, I'd use a sponge, but it's good.
I think it's very elegant. It's something I never would have thought about. And then I feel like we would have presented this case at our surgical conference, and some of our more senior people would have been like, you should do this. And I would be like, what element are you talking about? What does that look like? Do we have that? So I think it's elegant that you guys used it, but I don't know if I would have known to sort of go to that.
Well, and I think one reason we thought about it, because Dr. Murthanjaya, like you said, maybe you'd be fine without it. I feel like Dr. Mamo, to some extent, wanted to really decrease any chance of needing to reoperate on this lady. We had actually tried to operate on her a week prior, and given her dementia, she had gone downstairs with her normal routine and eaten the morning of. And we'd had so many difficulties arranging surgery for this woman. We just wanted to maximize the chances of her staying attached. So I think that was at least one of the factors that drove us to place this element.
Let's see you do it.
So we felt it was a little wider than we needed, especially with the extraocular muscle right there. And then we trim it down to the width of the buccal just so that we're getting that little kind of kick of support from the lip posteriorly. And actually, it's a little hard to see here, but it actually sits very nicely right under our retinotomy site.
Perfect.
It's a perfect retinotomy placement, Jacob. Nice work.
Posterior
It was meant to
retinotomy.
be.
That's right.
It was meant to be.
So we still have a little bit of residual choroidals, and our detachment or our retinotomy site has that funny bumped appearance, but that's because of the buccal element. And then here we are, we decided to go straight to oil. And so naturally,
Awesome.
having had oil and a buccal, we suture our sclerotomy sites and close up.
Nice. Some would
Nice job,
argue
Jacob.
gas in the setting of choroidals, because there would be a little bit of expansion, maybe helps to kind of hold things in place. The big risk, and I don't think here the choroidals were significant, would be, once the choroidals go away, you have a slight oil underfill. So that would be the only issue. There's all superior stuff. I think C3FA would have been awesome as well, but this is good.
Yeah, we had actually discussed that as well, our concern that with choroidals, maybe she will get an underfill, but we weren't too certain of her ability to participate in positioning. Granted, with it being superior pathology, it probably would have been fine, but I think we were just trying to be as conservative as possible. Unfortunately, we deliberately tried to almost overfill to minimize the chance of underfill. And post-operatively day one, she was looking excellent. I mean, her choroidals had largely resolved. Her visual acuity had improved to count fingers at 5 feet. Pressure was excellent, and she was felt to have a pretty good oil fill. But unfortunately, when she wasn't able to come for her post-op week 1, so she wound up coming a couple weeks later. And at that time, she felt like her vision had acutely worsened again in the past couple of days. And at that time, vision had gone back down to hand motion. And the exam was kind of limited, but it looked like maybe that retinotomy site had actually detached with perhaps some oil having gone subretinally. So we are now planning to do her next surgery, which hasn't happened yet, but that'll most likely be a combined phaco oil removal with vitrectomy, membrane peel retinectomy, and then we're thinking probably back to oil again.
Well,
Yeah,
Nice job,
sounds
Jacob.
okay.
this is really good. Really good. Wow.
You just have to make sure she doesn't eat for the next surgery. I think
Yes.
this is the person who ate, I think she ate the day of her surgery too, right? And he was delayed, I think, until the afternoon.
Yeah, so that's a good point. She ate, the first time we tried to operate, she ate so much that the case was canceled. And the second time when we actually did the case, she still ate that morning, but we were able to go in the afternoon. So hopefully she doesn't eat this time.
I mean, I get hungry too in the morning. If someone told me not to eat, I'd sneak down and get food too.
Exactly. And then I thought kind of the dimensions of some of these elements was interesting. I'm fairly familiar with the 4170, which we use commonly, but this 112 meridional element I was less familiar with. And so this is just some of the dimensions of it, if anyone's curious.
Nicely
Awesome.
done,
Thanks so
man.
much, Jacob. Great case.
Yeah. That's all.
Sometimes when I throw the extra element, I will throw another suture around it. It just depends on how well I think it's sitting. So sometimes if I want I want that effect, I will throw a suture around it, another mattress. It's just something to be aware of. You don't have to. You can sometimes just sneak it in without it.
Yeah.
I think this was an amazing first COBRA of the academic year. What a great job by all of our fellows.
Absolutely.
And our attendings who sat there, except for Prithvi. All the attendings who give some great advice to teach our fellows through this. Prithvi, when's our next one, man?
So next one's Monday, October 2nd, at 6 p.m. Pacific, 9 p.m. Eastern. And we have another one, Sunil. When's our next one after that?
We got our COBRA After Dark at the Academy on Friday, November 3rd. Our venue is almost being finalized, but we hope everyone can make it. We had a great one last year, a lot of fun, great cases, food and drink. Everyone got to hang out, say hello to each other. It was a really nice time. We hope you can join us there.
So
it
it's
should be a really,
Friday.
really fun
It's
time.
Friday after the first day of sub day, so that evening, right?
Correct, 7 p.m. to 10:30, I believe. So not all that time will be for cases, but you know what? We don't want to say where yet, Prithvi, because we haven't signed the contract. So let's wait before we say where.
I'm excited because it looks kind of cool. And what's the dress code, Sunil?
Whatever Prithvi's wearing. So God knows. I believe
we're wearing pink for Carolyn Pan.
Okay, pink for Van. Is that what we're doing?
Power pink for Pan. Or Taylor Swift gear.
Okay, T Swift gear. Oh, maybe your favorite pop star. Maybe that could be it. That's what we should go with.
Costumes. Thanks again to Bausch & Lomb for their support and everyone's comments and contributions. So have a good evening, everybody.
Thanks for coming. Have a great night.
Thanks, everyone.
Bye-bye, Sunil. Thanks.
Bye, guys.
Bye. Ciao.
Ciao. He is adorable.